At the end of this session, you will be able to describe the management strategies available for dementia in the primary care setting. Management will target both cognitive symptoms as well as behavioral and psychological symptoms. For this, both pharmacological and non-pharmacological methods are used. Cognitive enhancing medications include acetylcholinesterase inhibitors and memantine, which is an NMDA receptor antagonist. These medications have specific indications depending on the type of the illness as well as the stage of the disease. Also, the side effect profiles of the medications differ from one to another. For behavioral and psychological symptoms, pharmacological management is not the mainstay of treatment. Cognitive enhancers will help to improve some of these symptoms. In severe disturbances, careful use of other drug classes like antipsychotic and antidepressants can be done depending on the type of the symptoms. Non-pharmacological management strategies includes various types of behavioral therapies and environmental modifications. These will also include educating and training of the caregiver as well. These techniques need specific instructions and instruments, but often the principles can be used easily at home environment to contain the behavioral symptoms. Cognitive simulation and compensatory strategies need to be practiced for cognitive symptoms. Let's outline some important points with regard to dementia patients at primary care level. Patient and family may deny or be unaware of the severity of cognitive or functional deterioration. So we can miss the diagnosis. The diagnosis is clinical and need to establish the loss of independency. One of the important points is that any acute change in the clinical picture may indicate delirium on top of dementia. So look for features of delirium in such situations like clouding of consciousness. Often, we need some specialist opinion at some point. The illness is progressive and will have some poor prognosis. Hence, timely pharmacological input with the help and advice from a multidisciplinary team is important. Also, multiple comorbidities the rule rather than the exception in old age. So, comprehensive assessment and input from other specialties is also important. After initial input, the continuation of management, follow-up, and adjustment can be done at primary care level. Cognitive impairment can be contributed by many correctable causes. One of the important tasks we can do at primary level is promptly looking for these and correcting them. Comorbidities like depression, substance abuse, visual and hearing impairment, medication side effects, vitamin deficiencies, and endocrine abnormalities are among them. Always encourage for cognitive and social stimulation at their routine environments and give practical advice to the family and the caregivers at each visit. Always guide the family about non-pharmacological management methods. Caregivers need to be given the understanding about the illness so that they won't confront and challenge the patient's behavior. Often, there can be a reason or need for the patient which gives rise to the behavioral and psychological symptoms. Family should be guided to identify the possible reasons and address them. Environmental changes, changing interaction pattern by the caregiver, and distractions may help. In difficult cases, we can seek advice from specialized treatment teams. We need to make the caregiver understand the patient's inability to learn new information. The carer will be frustrated oftentimes than not due to the behaviors of the dementing patient. Encourage the patient to make full use of remaining abilities. Memory aids and environmental modifications will help in early stages. Maintenance of patient's physical health and fitness is essential. We need to advise the family about the need for being vigilant about the possible risks that the patient can face due to his or her various incapabilities. Remember to assess the mental status of the caregiver and to support him or her. Continuation of anticholinesterase drugs and memantine with optimization and side effects monitoring can be done at primary care level. Try to avoid sedative medications all the time. Optimize medical management of comorbidities with relevant timely investigations. For some disruptive behavioral problems, very low doses of atypical antipsychotics may be used. Try to reduce or withdraw every few months on a trial basis as they have significant side effects on their own. Refer to a specialist when needed. There are resources that can be used to help the patient and the families. Elderly rights promotion assistance, Department of Social Services, non-governmental organizations, and local social services, self-help groups are some options. You can make referrals to specialized psychogeriatric clinics at NIMH or the National Hospital of Sri Lanka or the Colombo South Teaching Hospital or the Colombo North Teaching Hospital for further management and inputs. Prevention will be the best option we have to fight the surge of dementia burden. It is no longer considered a disease in elderly as the risk factors tend to accumulate in much younger ages. Optimal management of cardiovascular and cerebrovascular risk factors is a must. Always promote regular physical exercises, adequate sleep, relaxation, and proper nutrition in any of the clients you meet at primary care level. Promptly address the loneliness, social isolation, and lack of interaction, smoking, and excessive alcohol consumption. Advise to keep the brain active with continuous cognitive stimulation, new learning, and acquiring of new skills regardless of the age. So take a minute and go through the main aspects of management we can do at primary care level. Finally, we need to be extra cautious on these few points. Presence of dementia make the patient highly vulnerable to delirium. It has to be detected and treated urgently as the consequences are detrimental. Lewy body dementia is highly sensitive to antipsychotics and use may lead to devastating outcomes. So avoid antipsychotics or take specialist opinion. Long-acting injectable haloperidol, tricyclic antidepressants, and benzodiazepines are best avoided in this group of elderly patients. Finally, always try non-pharmacological methods for behavioral and psychological symptoms. If needed, antipsychotics should be started at very low doses with slow titration. Thank you.